And we can start. Okay, so for the chief concern, we have a 26-year-old male who presented with diffuse abdominal pain and hematemesis.
Well, it's quite a start, my friend. Prof. Rez, I made the cardinal mistake of eating right before I know I was going to speak, so I'll power through it. But there's a couple of key dimensions here that I think are important to study. And I think the first thing to reflect on is how our minds are probably inclined to use the hematemesis to localize the abdominal pain. In other words, it's probably very plausible for us to say the cause of the abdominal pain is intraluminal because there is blood coming from the lumen. But you have to be very careful. Here are common examples of how abdominal pain and hematemesis may be completely unrelated. Here, a common example would be that you have any cause of abdominal pain that results in nausea, vomiting, resulting in a Mallory-Weiss tear, resulting in hematemesis. Less commonly, but more morbidly, you may have cirrhosis result in SBP causing abdominal pain, and that triggering a variceal GI bleed. So my advice to you is to not lump these two together until you have more data to link them more tightly. So I would be proceeding down abdominal pain and down hematemesis separately. And maybe I can reflect briefly on abdominal pain and pass the mic to Reza to share how he approaches hematemesis. And I want to be real with you. Diffuse abdominal pain in the ER or when you're first meeting the patient is not so much what is the cause. It is how do I get to the bottom of it? And for the vast majority of people, you get to the bottom of it by getting a CAT scan. That comes with a few caveats. First, you have to make sure that you're not dealing with an extra abdominal cause of abdominal pain, such as an acute myocardial infarction or a pelvic disease. In this case, the pelvic disease you might think of as testicular torsion, which you definitely should not wait for a CT scan to diagnose. Within the belly, the things that you can diagnose before a CT scan are things like hernia, zoster, pancreatitis, diabetic ketoacidosis, and urinary retention. So my antenna says, let me make sure this person doesn't have an MI, do a pelvic exam, make sure they don't have torsion. While I'm examining the pelvis, I should examine for a hernia. I should get a lipase. Among basic labs, look closely for a lipase and ketones. And if that's not the case, I'm probably going to need to scan the patient. But if the hematemesis is what dominates and the exam is mild, then I might just go down the hematemesis route and assume that the abdominal pain is from that. But that's an assumption that should be questioned if it doesn't read us down the right path. And now I'll pass the mic to Reza to reflect on anything, but share his magic about how he approaches GI bleeds.
Yeah, I don't know if there's going to be much magic here. I think that we need to know the degree of bleeding, and we can't even anchor on hematemesis. Like right now, we just know blood is coming out of this patient's mouth. Could it be an oropharyngeal bleed? Can it be hemoptysis? Or is it hematemesis? Maybe the abdominal pain prioritizes hematemesis, but I think that's one key branch point. Regardless of where the blood is coming from, whenever someone is bleeding, you need to check their platelets, their PT, and their PTT. You have to check these. Because as you're going down the journey, the diagnostic journey, you need to go down the management journey. So anything that you can reverse to help with stabilizing the bleed should be pursued. And going along with the management hat as opposed to the diagnostic hat, you want to make sure that this patient's protecting their airway. You see, this is quite a young patient. So hopefully they are protecting their airway, but you can easily see how hematemesis can lead to aspiration, which can lead to pneumonitis. And now you have two problems, not only intraluminal, but also pulmonary. So making sure that the airway is protected. You want to get IVs in this patient, large bore IVs. You want to get the type in screen. And so this is really what's going through my mind: a CBC, a PT, a PTT, good IV access, airway protection. And if this is truly frank blood coming from the upper gastrointestinal tract, a key question is whether this patient has cirrhosis or not. And the past medical history is going to be very helpful. Other things that can lead to frank bleeding from the esophagus includes aortoenteric fistula. Those are usually people who have a background of vascular disease, and he's quite young, though it's not exclusive to elderly patients that have vascular disease. But common etiologies include peptic ulcer disease, gastritis, and like Robbie said, if he's had frequent episodes of retching, a Mallory-Weiss tear. So to summarize, Robbie beautifully said that you don't want to anchor on the abdominal pain, but likely you're dealing with an intraluminal process. Make sure the blood is actually coming from the upper GI tract, check for cirrhosis and focus on management, and then get more history and allow that to prioritize your DDX. It's just striking that this patient is so young. So I'm very interested to see what else Franco has for us.
Great. So for the HPI, he presented to the emergency department with a history of intermittent diffuse abdominal pain for approximately 2 to 3 weeks, associated with occasional nausea, but no vomits. Until the day of the admission, he had already had one prior event of frank blood hematemesis, like half a cup. But on the day of the admission, he had 2 to 3 cups of frankly hematemesis in his home that made them go to the emergency department. With those 2 to 3 cups, he also had a near syncope event and general malaise. I think I can give you a little about the previous medical history. He was diagnosed with Evans syndrome when he was 15. Currently, he has been refractory to steroids and IVIG. He also had an splenectomy 3 years prior to this event, complicated with a surgical site infection due to a Klebsiella pneumoniae. He was currently with no medications. Regarding his family history, his mother died from lung cancer and no contributory social history.
All right, I think this is awesome, Franco, because you've given us a bomb here in the past medical history. And maybe Robbie, you and I can co-tackle the Evans syndrome. But I think we've already talked about the hematemesis and just dance together. So maybe I can just start by defining Evans syndrome. And then Robbie, maybe I can pass you the mic to start thinking about ways you can link that to the upper GI bleed and the hematemesis and the diffuse abdominal pain. So what is Evans syndrome? This is just an eponym. Basically, when you have an autoimmune mediated thrombocytopenia and hemolytic anemia, it's not only due to lupus, it can be due to lymphoproliferative diseases or other autoimmune diseases. But basically, the immune system is revved up for whatever reason, and this revving up targets red blood cells, resulting in an IgG warm-mediated autoimmune hemolytic anemia, and also an immune-mediated thrombocytopenia. So Robbie, that I guess is the basis of Evans syndrome. How can we link this to various causes of upper GI bleed, not to anchor, but just to explore the possibilities?
I love that. It's really just exploring rather than anchoring. I think that's a phrase that I should use more often. And when we explore that, we add stuff to the list, and the things that we can add are to speculate, to say, hey, could this be thrombocytopenia causing a bleed? But that would be unusual because thrombocytopenia usually shows up on the skin before it causes consequences of bleeding elsewhere. Specifically, the negative predictive value of a lack of petechiae or purpura makes thrombocytopenia as the cause of a GI bleed much less likely. And more importantly, you'll hear people say that you usually need a lesion to have flow platelets to bleed from in the first place. So the consequences of Evans syndrome are probably less likely, but maybe we can speculate on the cause of Evans syndrome. And just to put the pieces together, autoimmune hemolytic anemia is idiopathic in 50% of the cases and has a specific trigger in other 50%. The same numbers apply to ITP. 50% of immune thrombocytopenia is idiopathic, and the other 50% you find something. So then the question is, what if you have both autoimmune hemolytic anemia and ITP? What is the relative prevalence of idiopathic disease versus secondary? And thankfully here, intuition actually matches up with real life. Most patients with Evans syndrome, because you have two crazy autoimmune phenomenon, you'll probably find something in about 80% of patients. So what are those things? Reza mentioned the most common one, and the reason the names get mixed up is lupus is a big trigger of Evans syndrome. And in the lupus plus GI exists, but it's very minimal. There are a number of infections that can trigger these, including hepatitis B, hepatitis C, and HIV, all of which have varying degrees of association with the GI tract. But it's hard not to worry about hepatitis specifically, given the question that Reza laid out already with cirrhosis. And then finally, the autoimmune, we talked about autoimmune infection. Cancer is important too, and cancers involving the GI tract are very important. And finally, in a young person, you have to think about something we don't think about enough, and that is common variable immunodeficiency, or CVID. CVID is a notorious trigger of autoimmune disease causing hemolytic anemia and thrombocytopenia, and has prominent IBD-like GI manifestations. And Reza had a marvelous case that he presented on RLR, where there were a lot of GI and hepatic manifestations of CVID. So here, I think I would wonder whether Evans syndrome was looked into, and would pretty quickly look into the possibility of lupus, the possibility of cancer, and the possibility of CVID. All right, Franco, back to you.
Great. So for the vitals, the temperature was 36.5, heart rate 120, the blood pressure was 90/60, respiratory rate on 20, SpO2 98 on room air. He looked ill appearing, general pallor. Regarding HENT, no adenomegaly, no oral ulcers. Cardiovascular was tachycardic, but regular, no murmur or gallops. Pulmonary lungs were clear to auscultation bilaterally. Abdominal, mild tenderness to palpation on all quadrants, with no wording, no rebound, no masses, no organomegaly, only the cicatrization for the splenectomy that he had 3 years prior. Neurological was normal. The skin, no rash, no purpura, no petechia. There were some patchy areas of deep pigmented skin consistent with vitiligo in both hands and thorax.
I'll just summarize this exam briefly and then pass the mic to Reza to see what I've missed, because I think we can fly through it. And the immediate glance is, the patient is very sick. They not only have hematemesis, but they may have hemorrhagic shock, as evidenced by their tachycardia and hypotension. I'll say most people with hematemesis don't have much abdominal pain, because the problem is localized into the lumen itself, unless there's an extraluminal problem like SBP, or that they have an ulcer that is perforated. So here, the lack of prominent abdominal tenderness is common, and it's also reassuring that there hasn't been frank perforation. And then the vitiligo just adds to the list of things that are autoimmune in nature, and even probably increases the odds that there's a secondary trigger beyond just autoimmune hemolytic anemia and thrombocytopenia. So I think you deploy what Reza outlined: 2 large bore IVs really quickly, no evidence of cirrhosis on exam, but stay open to the possibility that cirrhosis is hiding underneath with ascites or fluid, with ascites or, of course, liver, and move very quickly to understand the cause of this GI bleed by understanding the labs, but probably having to take a look with endoscopy pretty quickly. But those are my reflex thoughts. Anything to add, Rez?
No, I think that's stellar. And like, what I'm trying to think here, Robbie, is like this severe abdominal pain and the GI bleeding. Of course, we're going to be interested in the CBC and the INR and the PTT, but also just thinking about hypercoagulable conditions and possible mesenteric vein thrombosis. So can you have clot and bleeding? So in this particular patient, I think a CT scan is going to be warranted, but also getting the venous phase in addition to the arterial phase to look for any arterial or mesenteric vein clots.
Can I just say, I think that's a brilliant thought. I really like the clot resulting in bleeding. It's such an important thing. Thanks for mentioning.
Great, so ready for some labs. The hemoglobin was 8.7, MCV 84, MCH 29. Leukocytes were 7,000, platelets 15,000. The VMP was unremarkable, CRP 1.53. According to our lab values was high because the normal values are up to 0.5. INR 1.21, GDP between normal limits, LDH 380, positive direct and indirect Coombs. Haptoglobin was less than 10, normal values according to our labs between 30 and 200. We also repeated all the immunoglobulin immune panel with ANCA negative, ANA negative. A thrombophilia panel was recovered from the prior history that was also negative. HIV negative, CMV, Epstein-Barr's, COVID, all of those came back negative. Regarding the liver function test, the AST was on 279, ALT 365, total bilirubin 2.3, direct bili 1.17, the albumin was on 3.45. I think I can stop there.
Awesome. Thank you so much, Franco. Maybe I'll just comment a little bit and then pass the mic to Robbie to come. Maybe I'll just talk about the CBC and the LDH. The CBC shows us that this patient is thrombocytopenic, and the thrombocytopenia, it's important to recognize most likely this is ITP, which is idiopathic thrombocytopenia or immune-mediated thrombocytopenia. Now, what you need to ask the question, is this enough to explain all of the bleeding that's happening in this patient? So I just want to teach for 30 seconds about thrombocytopenia and bleeding. Generally, if your platelet count is above 50,000, even trauma, like minor trauma, shouldn't cause bleeding. If your platelet count is less than 50,000, then trauma, like surgery, can lead to bleeding. If your platelet count is less than 20,000, then minor trauma can lead to bleeding. If your platelet count is less than 10,000, then you're at risk of spontaneous intracranial hemorrhage. So remember that number if you remember anything, 10,000. But I think that it dismisses something, because typically when patients have ITP, they have immature platelets. Immature platelets that get released, these are giant platelets. So if you did a smear and if this patient had a healthy marrow, they're actually quite sticky. So in this patient with a platelet count of 15,000, if you check the immature platelet fraction, if that was elevated, then that adds even more justification that this bleeding isn't spontaneous. So I think we have to operate under the hypothesis that a platelet count of 15,000 due to ITP should not lead to spontaneous bleeding, unlike a platelet count less than 10,000. But already I'm thinking, does this patient need immunosuppressive therapy, like high-dose steroids? Does the patient need IVIG? Does the patient need Plex, just given the acuity of their presentation? Looking at the hemoglobin, we know that when you have rapid bleeding, it really shouldn't change the concentration of hemoglobin. Like, think about it. If I'm losing blood, it's the same concentration of what's left behind. So if my hemoglobin is 12 and I start vomiting blood, my hemoglobin should be 12 if you check it immediately after the hematemesis. But if you check it, 12 hours later, 24 hours later, if there's a delay, now there's time for volume to leave the interstitial space and enter intravascular space, and now the hemoglobin gets diluted. So when I see a hemoglobin, I think it was 8.7, not 9.7. Is that right, Franco? 8.7?
Excuse me, which one?
Was the hemoglobin 8.7 or 9.7?
8.7.
So when I see a hemoglobin of 8.7, I know that it's unlikely to reflect the acuity of bleed and that there is likely hemolysis going on here. And the hemolysis doesn't have to necessarily be acute. It can be sort of chronic low-grade hemolysis that this patient has adapted to, but the patient now is extra vulnerable to any perturbation like a GI bleed. So with the GI bleed and poor reserve, you're seeing the hypotension and the tachycardia in a healthy young patient. The LDH is mildly elevated, and the positivity of the direct and indirect Coombs tells us that it's a mixed pattern of autoimmune hemolytic anemia. Just very quickly to talk about the Coombs test, because I find this a very confusing topic, and then the mic to you, Ravi. The direct Coombs test, how do they do this? They basically take the patient's blood and they mix it with serum, like anti-sera from like an animal, to see if the anti-sera cause agglutination of the red blood cells. So that's a direct Coombs. It's like direct blood of the human being to see if there's a reaction. And this patient has that. The direct Coombs is positive, and it's likely going to be IgG. The indirect Coombs is you take the plasma, the serum, of the human, and you mix it with healthy red blood cells to see if there's agglutination. And that's more consistent with the C3. So this patient is showing us a mixed pattern of autoimmune hemolytic anemia. So anyways, the immune system is revved up. We need to calm it down. But what's going on with the GI bleed, and what's going on with the abdominal pain?
I love that analysis, and I love the reminder of the Coombs and direct and indirect. I actually completely forgotten that. I think the signal that we have is there's some liver involvement in addition to the labs that you analyze, Rez, and I'm not sure how far I take them in real life. I would note them, but the liver involvement doesn't appear to be in the setting of portal hypertension. So the AST and ALT are high, but the albumin is manageable, and the bili isn't too high, especially if we conjecture that there's a component of indirect hyperbilirubinemia, given the argument for hemolysis that you made. And the reason I wouldn't take the liver enzymes further is because they're often so nonspecific when somebody is ill, and they may represent an early form of ischemic hepatitis. But essentially, this is the level of liver injury is not significant to move the spotlight enough. Because it's just like the ATN of the kidney. There's not much that you can invest here, though it does, remind us that, again, hepatitis viruses can cause ITP and autoimmune hemolytic anemia. Lupus can involve the liver, and so does CVID, as your case from a while ago prominently reminded us. So I think you're right. Like we have to work in parallel with, there's autoimmune hemolytic anemia and autoimmune thrombocytopenia, and there's also bleeding going on, and approaching those separately now till we see if we can wrap them in a neatly tight bow. All right, Franco, back to you, my friend.
Okay, so I have like 2 more key exams. The last one is going to reveal the exam. So we did an endoscopy, an emergency endoscopy. We were kind of amazed because the endoscopy showed multiple grade 4 esophageal varices and grade 1 gastric varices. We also performed a colonoscopy that was normal. A fibro scan was made also, and it was not compatible with cirrhosis. I think I can leave that.
Oh, shoot, I'm up. I'm sorry. This is very surprising results, I have to say. Although I will tell you that Reza texted me and called it. He was like, "Oh, I wonder if they're gastric, is this the variceal bleed?" And I think what we learned is how humbling it can be to predict portal hypertension, especially because we often make the assumption that portal hypertension is from cirrhosis, but that's not necessarily true. You can have a lesion anywhere in the venous system distal to the portal vein that causes high pressure, and the reason is usually fibrosis from cirrhosis, but it can be many other things. And so, I would approach it anatomically by saying, is there a heart problem? Is there a IVC problem? Is there a hepatic vein problem? There doesn't appear to be a cirrhotic liver problem, or is there a portal vein problem? And that's where my analysis would be at. We know that the patient has portal hypertension. We know with the FibroScan that it's probably not cirrhosis. And the question is, what is the source of this elevated pressure? And Reza had some thoughts even before we had this aliquot, so I'll pass the mic to him to share them.
Yeah, no, I think, Ravi, this brings me back to the case that we discussed with the A and how many editions of that drawing it took to satisfy our mentor. But basically, we have portal hypertension here, without a doubt. There is portal hypertension, and it's non-cirrhotic portal hypertension. And meaning because the liver is totally normal, the INR is not elevated, and we know we have a reason for the platelet count being low, and there's no stigmata of cirrhosis. And so I think we're dealing with probably portal vein thrombosis. And because I remember, Robbie, correct me if I'm wrong, on Twitter, we had splenic vein thrombosis, but someone corrected us. Like, I don't remember do you remember the logic behind why splenic vein doesn't cause? I don't remember exactly, but in any case, we're dealing with probably portal vein thrombosis, and we're dealing with an autoimmune disease. So the question is, what autoimmune disease is leading to portal vein thrombosis, autoimmune hemolytic anemia, and ITP? So right now, regardless of what it is, this patient needs like probably high dose steroids, like 1 gram of IV methylprednisolone, or IVIG or something to calm this immune system down. And then you need to go down Robbie's list of autoimmune diseases and see which one adds up to explain, this hypercoagulable state that how crazy is it, huh? The platelet count is low, but the patient is hypercoagulable. That tells you that's not what's causing it's the high pressure that's causing variceal bleeding. Fascinating.
Okay, so we did a contrast abdominal CT that show eventually signs of chronic portal vein thrombosis, also a superior mesenteric vein thrombosis. The patient had an splenectomy, so he didn't have an vasculature because of that. So it doesn't have a splenic vein over there. The problem was that given that this patient has the splenectomy and was complicated due to an infection, it was probably due to a chronic thrombi, like a pilophlebitis picture, or because of the splenectomy, they probably didn't because of the Evans syndrome and the thrombocytopenia, they didn't put him on coagulation prophylaxis after doing the surgery. So we were kind of in the middle of, it was because a complication of the infection, it was a complication of the surgery. And the main problem with this patient is that there wasn't a good vein to derivate the flow. He wasn't a candidate for the tips. Normally when you correct the portal vein thrombosis, you derive the flow to the splenic, but this patient didn't have a splenic. So the surgery team tried to propose like a Surgiura procedure. That is something that disconnect the esophageal veins of the whole system and wait until the patient has developed cirrhosis and making a candidate for transplant. But he was also with the problem with the Evans syndrome, so he put them on steroids. And the problem with steroids is that they made the tissue so friable. So eventually this patient had another mortal episode of GI bleed due to the portal vein thrombosis, and he died waiting for the procedure.
Oh, geez, Franco, that is a tragic outcome of this case. I think it's incredible how we all think that somebody who's 26 is going to be healthy, and even if they have Evans syndrome and they have a splenectomy, we still expect them to have a longer and longer lifespan. And I think that's incredible. Despite those two medical illnesses, we have so much expectation and so much ability to help people. But when you have portal hypertension, period, your prognosis is limited for sure. And it's unfortunate that this person had this outcome that they did. But I think it's an incredible reminder of the consequences of surgery. When people take spleens out, we think, oh, it's, you do prophylaxis against infections and that's it. But the anatomical complications are very powerful. Thank you for sharing this case. I learned a lot. I think it emphasizes the separate but related concepts of cirrhosis and portal hypertension. And just like you can get lower extremity edema bilaterally without heart failure, you can have it because of venous stasis or local issues. Remember that you can get portal vein issues, just like leg issues, independent of disease in the proximal organ. So you can have bilateral lower extremity edema just from local problems with the veins, like venous stasis, without heart failure. You can have portal vein hypertension and leak from the portal vein and clot in the portal vein without having disease in the organ that's upstream from it, the liver. And while you should link those two concepts, because 90% of portal hypertension is from cirrhosis, you have to be open to the 10%, in which case it's not. And I think Reza tying in the abdominal pain early on and linking it to a hypercoagulable state illustrates the importance of thinking beyond that connection. And I think that hypothesis is reinforced here in a really nice way of linking an intermittent abdominal pain with hematemesis. Prof. Rez, thoughts, reflections?
No, I echo that. And it just, although this is like an interesting case, fascinating case, and thank you for presenting it, Franco, there's a very thin line that separates us from our patients. And this can happen to anyone. And so I think being very grateful for our health, our family health, our friends' health, our patients are, a constant reminder of that. And I just think it's very unfortunate and it's sad. It's a reality, but there's an invisible line that separates us. This could be anyone. So, but thank you so much for presenting the case, Franco. Maybe I'll pass the mic to Laura. Unless, Franco, did you have anything else you wanted to teach us before we give it to Laura to do the teaching?
I think the most important thing that I learned from this case is that although splenectomy is a good treatment of choice for Evans syndrome and IDP, we have it's kind of the last resource that we can use. We can try rituximab, we can try another immunosuppressants before doing a splenectomy. And if the splenectomy is going to be performed in a patient with IDP, be aware that after removing the spleen, there will be a high burden of platelets. So don't be afraid to put on coagulation prophylaxis after the procedure. It is like a thin line between bleeding because of the thrombocytopenia and going to get in a hypercoagulable state because of that. I think, Laura, we can go to you.
Thank you, Franco, for that fascinating case. Sad case, but fascinating. So for the teaching points, we started with hematemesis, and we thought about the causes, which could be cirrhosis, peptic ulcer disease, aortoenteric fistula. And Reza told us about the management. We should check the platelets, PT, PTT, and protect their airway because of the risk of aspiration, and also large IVs. And for the diffuse abdominal pain, we thought about gastritis, hernia, herpes zoster, pancreatitis, urinary retention, and extra abdominal causes such as pelvic disease. Also vascular, arterial or venous clots, perforation or obstruction. And he had that Evans syndrome diagnosed. So it is an autoimmune mediated thrombocytopenia and hemolytic anemia. And it's 50% of the cases it's idiopathic, but the other 50% has triggers, which could be lupus, hepatitis B, C, HIV, and CVID. And we also linked thrombocytopenia with bleeding, and Reza told us about the platelets, that if it's below 50,000, trauma or surgery can cause bleeding. Below 20,000, minor trauma can cause bleeding. And the most important number is 10,000 because it could cause spontaneous intracranial bleeding. And rapid bleeding shouldn't change the hemoglobin immediately. So we thought that the patient should have chronic hemolysis and is extra sensible to trauma, which explains the extra low hemoglobin. And also Reza explained about the Coombs, direct Coombs, which is performed with the patient's blood and healthy serum. And if there is agglutination, then it is positive, and it is mostly IgD pattern, IgD involved. And indirect Coombs, which is patient's plasma and healthy red blood cells. And if there is agglutination, it is positive, and it is mostly C3 involved. So the patient ended up having non-cirrhotic portal hypertension, which is only 10% of the cases due to chronic portal vein thrombosis. So thank you so much. It was amazing, and I'll see you tomorrow.
Superb, my friend. Nice and smooth as per usual. All right, I will see you tomorrow for another very special Global Morning Report, where the one and only Ravi will be interviewing Rafa Sakriti, who will knock it out of the park with superb interview skills. And my job is to show you what you shouldn't do, which I really, really look forward to. I'll see you then. Bye.